Thank you very much, sir, for that informative session. Next up, we have Dr. Renoy A, sir. He's an associate professor in the Department of General Medicine at AMRITA Institute of Medical Sciences. He's a great teacher, highly competent physician, and a compassionate doctor who is committed to provide the best care for his patients. I welcome you, sir, for the session.
Good afternoon, everyone. Welcome to my talk on ATT in comorbid illnesses. Definitely, it's one of the stumbling blocks that we face as physicians, and I hope at the end of this presentation, we can use that as stepping stones to actually progress in our clinical practice. Before we start this particular lecture, I think it is important that we know something about the changed paradigms. Okay, the control program has been changed to National Tuberculosis Elimination Program, and the target is to 2030, probably Indian target being 2025. CBNAT, that is a cartridge-based nucleic acid amplification test, and drug susceptibility test are important parameters now. And it's a daily regimen and also a weight band based regimen. Ethambutol is actually continued even in the continuation phase as a change that has been brought in. Private partnership, especially with private hospitals, have been encouraged, and also notification has become an important part of the TB management. With this brief introduction, let's go to a case scenario. In the COVID ward, a patient who is presented with mild COVID. These are the comorbid illnesses that the patient has. Patient is a 76-year-old gentleman. He was undergoing evaluation for a generalized lymphadenopathy and weight loss in the hospital. FNAC was done, which showed a caseating granulomatous inflammation. Unfortunately, had an upper respiratory tract infection at that particular time and detected to be COVID positive and shifted to the COVID isolation area. While in the ward, patient's gene export report comes and is positive for Mycobacterium tuberculosis. So how do we proceed? What is the ATT drugs that we would look at because of the comorbid illness that this patient has? What regimen? Should we do a daily regimen, or should we actually have an intermittent sort of a regimen, especially with the comorbid illnesses? Dosage modifications, especially when you consider CKD and CLD, what are the implications in such a scenario? Drug interactions, especially because the patient is on multiple drugs because of all the comorbidities that are there. Special scenarios like the fact that the patient is elderly and having significant amount of diabetes as well as hypertension and dyslipidemia. And finally, COVID adds on to the confusion like always in the current scenario. So let's try and find some answers in this particular session. The comorbidities that I'm going to list are what I've actually enlisted here. We'll start with the first one being a physiological condition, pregnancy. So according to the safety class of drugs, no class is actually coming in A. No class of drugs is coming in the safety class A. However, ethambutol comes in class B, but predominantly all the ATT comes in class C, where animal studies have shown risk and caution is advised. However, benefits usually outweigh the risk that is involved in these kind of patients. The basic dictum is that untreated TB is definitely a greater hazard to pregnant women and her fetus than treatment itself. So definitely it is important that we treat patients who are actually having or being diagnosed to have TB during pregnancy. Streptomycin is the only TB drug documented to have harmful effects on the human fetus, which is predominantly the congenital deafness. Pyrazinamide is recommended by WHO and the International Union Against Tuberculosis and Lung Disease. There's a lot of confusion regarding pyrazinamide. But if a physician decides not to include pyrazinamide in the initial intensive therapy, then the therapy should be extended to up to about 9 months. I'm not going to discuss MDR-TB and XDR-TB in this particular because of shortage of time, but this slide has been portrayed because it is important to know that if the patient is less than 20 weeks and has been detected to have MDR-TB, MTP or medical termination of pregnancy should be offered to the patient. I will not discuss the other drugs in this particular scenario. Coming to the next comorbidity, that is lactation. So breastfeeding should not be discouraged for women being treated with first-line anti-tuberculous therapy because the small concentration of the drugs that could be excreted in the breast milk usually does not produce toxicity in the nursing newborn. Supplementary pyridoxine is always important and should be given to the mother who is on isoniazid therapy. Now, just because there is some amount of excretion of the drug, it does not serve as effective treatment for patient on latent tuberculosis or active tuberculosis, especially the nursing infant. So this is out of our purview because this comes under neonatal medicine and pediatric medicine. So we'll proceed to the next comorbidity, that is elderly. Now, it is very important, and we all know that significant amount of decrease in renal clearance as well as a hepatic metabolism occurs in elderly, and this can add on to the adverse effects and potential serious life-threatening events. However, when I scan through most of the guidelines, no significant modifications are advised in most of them. Closer monitoring, obviously, of the parameters have been advised, but in this particular guideline, that is the IDSA guidelines, it has been mentioned that if a patient is more than 75, I think the most implicated drug being pyrazinamide, I think it would be better if you look at certain other parameters like bacillary burden as well as a risk of drug resistance. Now, if it is low, then probably you can avoid pyrazinamide, but you extend the treatment for about 9 months. Now, if both these parameters are high, then probably adding a pyrazinamide is still probably a safer option, probably will have with definitely adequate monitoring. Now, fluoroquinolones is another thing, and I would prefer fluoroquinolones if patient does not have neurological dysfunction, seizure disorders, and other things like that, which can precipitate seizures. So this is the only guideline which I found in IDSA, which actually tells probably pyrazinamide can be avoided in this. But this is probably an expert opinion rather than a guideline. Coming to the next important thing, that is CKD. I mean, it's very well known that because some of the drugs, anti-tubercular drugs, are cleared by the kidneys, renal insufficiency becomes an important comorbid illness which we need to know how to manage. Now, alteration in the dose of anti-TB drugs is commonly necessary in patients not just in renal insufficiency and end-stage renal disease, but also requiring hemodialysis. Certain changes have to be brought in according to the timing of the medications, especially when the patient is undergoing hemodialysis. What are the drugs? I think it's clearly mentioned with the color algorithm. Isoniazid and rifampicin, because predominantly it is metabolized by the liver, is significantly safe. Whereas ethambutol and aminoglycoside, which are actually about 80% excreted by the kidneys, is significantly problematic because in renal insufficiency, the excretion is significantly reduced. Pyrazinamide, though metabolized in the liver, the metabolites that are pyrosinoic acid and 5-hydroxypyrosonic acid may accumulate in patients with renal failure. All these drugs, especially pyrazinamide, ethambutol, and aminoglycoside, can be found in significant proportion in the dialysate, and hence dosage modifications and timing is important in these particular drugs. Regarding CKD, I mean, we are all aware of the creatinine clearance based division of staging of CKD. Basically, isoniazid and rifampicin can continue the same in both all the three groups, that is stage 1 to 3, stage 4, 5 CKD, including hemodialysis and renal transplant patients. Ethambutol needs to be changed. The usual dose that we give is 15 mg per kg. It has to be given the same dose but on alternate days, especially during stage 4 and 5 and patients on hemodialysis. Pyrazinamide needs to be given at 25 mg per kg, again alternate days, especially when you are dealing with patients in stage 4, stage 5 and hemodialysis. Now, another issue that comes up is the timing during hemodialysis. There are two schools of thought. One is ATT being given about 4 to 6 hours before the dialysis. The danger there is premature drug removal. Whereas if you give after dialysis, the problem is the toxicity that can occur. Now, this decision has to be taken based on the expected pharmacokinetics of the drug and the drug interactions when we have other comorbid illnesses that are there. And there are certain practical issues are if the patient's dialysis in the morning, then definitely it is worthwhile to actually give it after the dialysis. And also adherence must also be better, especially when you give post-dialysis, because you can practice directly observed therapy. So in my opinion, and with all the other guidelines and usual practice, it is usually given after dialysis. In renal transplantation, definitely we know the most important implicating agent, that is rifampicin, or because it is an enzyme inducer. So it can interact with the immunosuppressive regimen and increases the chance of graft rejection. So the doses of the calcineurin inhibitors as well as mycophenolate mofetil may need adjustment. Corticosteroid treatment should be almost doubled in patients receiving rifampicin. Coming to the next section on CLD. Now, CLD makes things much more complicated because we all know that drug-induced hepatitis is greater in patients having advanced liver disease. The implications are potentially serious and even life-threatening because the hepatic reserve is very marginal in such patients. Now, the fluctuation in the indicators, that is SGOT, SGPT, or the bilirubin that we follow up in patients with pre-existing liver disease can confound the monitoring for drug-induced hepatitis. So it can be actually much more complicated. So clinicians and physicians must consider regimens with fewer potentially hepatotoxic agents, especially in patients with advanced or unstable liver disease. Definitely, if in doubt, an expert consultation is always advisable in managing such patients. Now, all three of them are metabolized in the liver, and the isoniazid acid is metabolized in two pathways. The problematic one is the amidase pathway, which actually forms a substrate of hydrosin, but the hepatotoxicity that it causes is idiosyncratic. The advantage here is that when you re-challenge it, it probably becomes not so problematic. Rifampicin causes conjugated hyperbilirubinemia, inhibiting the major bile salt exporter pump, impeding the secretion of conjugated bilirubin in the canalicular level. And this causes hepatocellular damages. Again, here the hepatotoxicity that occurs is idiosyncratic. Whereas in pyrazinamide, it is considered as a most hepatotoxic antitubercular drug. The free radical species mediated hepatotoxicity occurs, especially in high doses, that is about 40 to 70, but usually our dose is actually less than 35 milligram per kg. Now, according to the Child-Pugh classification and status, we have to decide. Now, A, B, C. In A, you can use two hepatotoxic drugs and probably add on pyrazinamide at a low dose that we mentioned in the last slide. If you are omitting pyrazinamide, then you probably have to give the duration to about 6 to 9 months. In child B, I think it is better that we give only one hepatotoxic drug and the duration has to be increased to 9 to 12 months. In C, because it's a severe case and unstable liver disease, no hepatotoxic drugs should be used. And second line drugs, obviously ethambutol can be used, and second line drugs like streptomycin, fluoroquinolones, etc. can be used. The duration will be more than 12 months. The problem here is the role of aminoglycoside is limited due to the reduced renal reserve in these particular patients. Having said that, predominantly most of the Indian physicians who manage the case, probably even in A and B, would try at least two hepatotoxic drugs, that is INH and rifampicin, and exclude pyrazinamide and substitute it with a fluoroquinolone. Now, how do you start this? Basically, you have a baseline AST, ALT, bilirubin, and creatinine. You initiate the ATT according to the grade of cirrhosis. Close monitoring is required, probably every 3-day LFT. Keep the albumin more than 3 gram per deciliter. If there is a rise in AST, ALT, or if there are symptoms associated with ATT-induced hepatitis, you also have to rule out other hepatitis markers to suggest and to rule out viral hepatitis or an HBV reactivation. Now, if it is more than 5 times the AST/ALT or bilirubin more than 2.5, and you establish an ATT-induced hepatotoxicity, you have to stop all the hepatotoxic agents. You have to then attempt to continue at least 3 non-hepatotoxic drugs like ethambutol, streptomycin, as well as quinolones. Now wait for the liver enzymes or bilirubin to settle down, then restart slowly with about 150 milligram per day of rifampicin, continue about 2 to 3 days, and then reassess, and then increase by 150 milligram every 1 week or probably 4 to 5 days. Now, you have to, at this particular time, continue on 2 to 3 non-hepatotoxic agents. Then, once rifampicin is tolerated, you start INH. Now, once you reach the full ATT, now full ATT, I don't think anybody re-challenges with pyrazinamide. So that will be substituted with quinolones. Once you complete the full ATT, the other temporary drugs which we have started can probably be stopped. Coming to the next important part, which is HIV, it is two important scenarios. I mean, you can diagnose TB prior to diagnosing HIV, most common opportunistic infection, and probably that is how most of the people are actually diagnosed. Sometimes people on management of HIV can be diagnosed with TB. So if the first scenario occurs, I think the ATT should be the standard regimen. The dosing interval, there is no confusion. It is daily dosing regimen that has to be done. And ART should be integrated ART rather than a sequential ART. Now, what do you mean by that? Integrated means if a CD4 count is less than 50, then you initiate ART after 2 weeks of initiating of TB treatment. If the CD4 count is more than 50, then the initiation should be about after 8 weeks. But however, in CNS TB, if they're irrespective of the CD4 count, you have to initiate ART only after 8 weeks. This is because of the serious adverse effects that can occur, including immune reconstitution syndromes. Now, if what is the latter scenario where HIV is diagnosed prior to TB, again the standard rules apply, but with certain caveats. So what are the caveats there? It is because of the rifampicin, which is actually, or rifamycin, which is the basic problem that is there, which is an enzyme inducer. There are a lot of interaction between these particular drugs. So I have put across a table sourced from UpToDate, looking at all the different classes of the drugs. I will not go to the detail of that. These are the preferred rifamycin molecules that are there in this. Now let us look at the NACO guidelines. This is the basic initial regimen that we start: tenofovir plus lamivudine plus efavirenz. Now if you go to this, it is clear that tenofovir, when you are using, you cannot use either rifampicin or rifabutin. So either option is to actually change that to quinolones, or if you want to change tenofovir, then you have to use abacavir. Okay, usually this is the first line of treatment in anybody more than 10 years or a weight band more than 30 years. Abacavir is used, this kind of a regimen, the second regimen is used when patients have renal disease or the weight band is less than 30. Now, the problem associated, whenever you use efavirenz, it is best to take efavirenz-based regimen and not nevirapine-based regimen. And efavirenz, the dose has to be increased from the classical dose of 600 milligram to 800 milligram. Now, about rifampicin and rifabutin, the first problem that occurs is rifabutin is not usually commonly available. Even if it is available, it is actually 10 or even more times costlier than rifampicin. So it is going to be a problem. So I think it is better to use regimen which can use rifampicin and probably make alterations in the ART in an Indian scenario. Again, expert opinion has to be taken when in doubt. Coming to drugs, drugs are a major problem because rifampicin is a major offending agent here. Cytochrome P450 based enzyme induction can occur and it can cause significant problem. The predominant problem is decreased parent drug exposure, reduced oral bioavailability, and increased clearance that can be seen. What are the interactions? Anti-infectives. Azithromycin has no problem, but clarithromycin can, especially when used with rifabutin, can cause increased toxicity of the rifabutin and can cause risk of uveitis. It's better to change doxycycline and other antimalarials if you are using rifampicin in this particular regimen of ATT. Ketoconazole and other azoles probably will become subtherapeutic and the dose has to be increased. OCPs, that is an important part. I think it is important because of the interaction that the patients who are on OCPs are advised a barrier method of contraception while on rifampicin. About anticoagulants, warfarin and even the newer anticoagulants, the dosage has to be increased. Warfarin has to be increased about 2 to 3 fold, especially when taken with rifampicin. Immunosuppressive drugs like cyclosporin, tacrolimus, and even corticosteroid, those have to be increased, as I discussed in the renal session. Anticonvulsants like phenytoin and cardiovascular drugs, everything requires some dosage modifications. Therapeutic drug monitoring is important in this situation, especially with anticonvulsants, and then the dose has to be increased. Similarly, with anti-diabetic drugs, especially sulfonylureas. Coming to some miscellaneous considerations that are there, silicotuberculosis. In such scenarios, it is important to increase the extension of continuation phase by about 2 months. Diabetes mellitus, if it is poorly controlled, about 9 months regimen should be given. Other immunosuppressive conditions also, there should be a consideration of extension of regimen. Rheumatological diseases, if the patient is on TNF alpha, ideally it is better to withhold at least during the intensive phase. Patients with solid organ transplant, we have already discussed interaction of rifampicin versus calcineurin inhibitors is a problem and has to be dealt with accordingly. Screening of HIV, hepatitis, malaria, parasitic infections, etc., are ideal, especially when you are actually looking at tuberculosis. But these are not coming in guidelines. These are expert opinions which have been mentioned in various guidelines. Coming to the last, I think we cannot end any session without actually saying about COVID, the pandemic that we are living with. Now, this is a graph which has been published in WHO. Now, because of the masking, this mask, this particular slide does not say that the TB cases have come down. That probably is the first impression that we get. But when you look at the dates, it is very clear that whenever a wave has occurred, probably because of the lockdown and other thing, there is significant decreased notification, both in the private sector as well as the total notifications. This is in comparison to this blue line, which is the 2019 notifications. But as soon as the lockdown has come down, you can see the increase. And again, the other spike, again, the notification has come down. So it is not because of better masking. It is because of probable lockdown and the waves, which actually caused people not to report, and the notification came down. So initial studies in China has shown that there is an increase to risk, that is about 2.21 times people are more likely to die, and 2.27 times people are likely to more develop severe diseases if you have TB and COVID-19 as diseases together. Now, this is just few days back, just couple of days back, all the major newspapers have suggested, according to the new Omicron strategy, that TB has been flagged as a comorbidity in new COVID clinical management protocol. And it is important to avoid steroids and also to get tested for TB if the cough persists for more than 2 to 3 weeks. Now, all these things have already been covered. Antivirals like remdesivir, corticosteroids, and anticoagulants, including the new anticoagulants, co-administered with rifampicin, can lead to decreased level, and those have to be increased. I do not have data about molnupiravir, but remdesivir definitely reduces the levels in conjunction with rifampicin. Coming back to the case scenario, this is a profile that we have already looked at. Now, how will you start ATT? And it's very clear that isoniazid is definitely required in the standard dose. Rifampicin is required in the standard dose itself. Pyrazinamide. Now, this is a little confusing. Though it's a childhood cirrhosis, probably pyrazinamide can be given, probably as an alternate day regimen, even though it is CKD5. But having taken that particular expert opinion that elderly people, along with diabetic and other things like that, it's better to avoid pyrazinamide, especially patient having child A cirrhosis, I would choose levofloxacin. Initially can be given as a loading dose of 750 and then 500 milligram alternate dose. But the current strategy says that whenever you can give a daily dose, probably that is better. And so I have chosen 250 milligram daily dose over 500 milligram alternate days. Ethambutol can be given according to the CKD stage 5 criteria of 800 milligram thrice a week. Now, when to time it? Definitely after dialysis. And how long will the regimen be? Should it be 9 months? I feel I have chosen 6 months because I have added levofloxacin instead of pyrazinamide. So we are still giving a 4-drug intensive therapy and continuation with 3 drugs. So I would just observe and probably stop it at 6 months and then clinically assess the patient and see if there is a need for a probable increase in the dose. Now, COVID was a mild COVID, does not require antivirals and other things like that. So no interactions there. Interactions with the other drugs, probably cholesterol medications like statins, probably can be withheld initially at least, so that patient does not have significant problems. Definitely, it goes without saying that the glycemic control and antihypertensive control has to be optimal. So thank you very much for the opportunity to the organizers of this particular CME. And thank you very much for a patient here. And I hope we achieve the target of ending TB by 2030. Thank you once again.
Thank you, sir. Thank you, sir, for that crisp and clear presentation, sir. And you really helped us understand the world of comorbidities with ATT. So actually, one common issue physicians face is when chronic liver disease patients get tuberculosis, and we are forced to initiate ATT in spite of the several dangers that ATT presents in liver disease patients. So can you share some of your experiences in using ATT in CLD patients, sir?
Yes, am I audible?
Yes, sir. Yes, sir.
So I think though the guidelines say that child A and child B and child C, one of the important considerations that we should know is, see what constitutes these child A. I mean, ascites, the bilirubin concentrations, etc., are also a part and probably can be elevated because of the TB itself. And I have had a case where a patient was presented with FUO and had been newly detected with chronic liver disease outside, especially because of the alteration in the echo texture in the liver in ultrasound, significant hypoalbuminemia, etc. In such scenarios, it's confusing whether it is the new onset liver disease or it's probably as a part of the TB itself, granulomatous hepatitis, or a problem associated with an obstructive sort of thing. It's because of the lymph nodes. So it is better to start. And as a protocol, I think what I follow, especially in child A and child B, and probably in certain cases of child C also, to avoid pyrazinamide completely, but substitute it with levofloxacin or moxifloxacin during the intensive phase, along with INH and rifampicin. Carefully monitor these patients and then actually take it forward. If they develop drug-induced hepatitis, definitely stop, and as per the protocol that we have already mentioned, go back and use other agents or non-hepatotoxic agents, and then come up and slowly reintroduce and re-challenge the patients with INH and rifampicin and continue levofloxacin. That would be my approach.
Thank you, sir. So, and so this in your example, I noticed that so you had actually included levofloxacin even though the patient was 76 years old. Like we are all sometimes hesitant in elderly patients, no, starting because of the adverse effects. So, what is your comments on that, sir?
Yes, I mean, there are two ways of going ahead with it, because if you look at it, you can choose a regimen without pyrazinamide or levoflox, and then choose to actually continue the regimen for 9 months to 12 months, or you can take the risk. Now, just because the patient is elderly, I don't think we need to actually be extremely cautious, because I understand neurological problems and other issues associated, metabolic dysfunctions, etc., can precipitate seizures. Patients can have cartilage dysfunctions, tendon injury, and a lot of other issues when taken for a long period of time. But when we weigh risk versus benefit, I feel it is better to actually add a quinolone instead of pyrazinamide and then proceed. But again, a good amount of monitoring is always important.
So, and one more thing, sir. Actually, most of the guidelines, sir, you mentioned so many guidelines. Actually, are all these applicable for pulmonary tuberculosis and extrapulmonary in equal measure, or is this
Yeah,
only for
yeah, yeah. It is actually in equal, both pulmonary and extrapulmonary tuberculosis. I don't think there is any difference, because the newer guidelines in the elimination program actually do not differentiate between category 1, category 2, category 3. We do not have that kind of a differentiation at all. So I think we can take everything together and treat it accordingly.
So, and one last, so we came across all these guidelines, right? And so finally, when we see a patient with tuberculosis and who's having comorbidities, is it up to the patient, physician discretion to select the treatment, or should we go strictly by the guidelines?
That always is the case, because see, guidelines or protocols can just set a guidance. I think finally the patient is under you, and you have to take a decision. You have to individualize treatment, definitely. And more importantly, the guidelines, most of it, if you see that I have mentioned, IDSA or any IDSA, CDC, WHO, most of them do not actually target Indian population, isn't it? And Indian population, I think Indian doctors predominantly have the most experience in handling tuberculosis cases. So I think our local experience have to be actually brought out. The training that we have got in our institutions actually have to come out, and we have to develop a personalized approach towards treatment, but definitely should not alter the guidelines completely. Okay, that means drugs should not be completely stopped random or added randomly, but within the framework, I think you can make certain alterations, which is allowed. I think that is very important.
Okay, sir. Thank you, sir. Thank you very much for your comments and the presentation, sir. We shall move on to the next. Over to you, Rahul.
Thank you once again for the opportunity.
Thanks.